Wonderful, and good afternoon to everyone who's joined us this afternoon for webinar number 7, Epilepsy, Making Epilepsy a Health Priority in Africa. My name is Comfort Musa. I'm a journalist and I'm joining you from Cameroon. And today our session will be recorded. And also throughout the session, I just want to plead with us all to mute our microphones and only speak when we're given the chance to. As usual, today we have great speakers lined up to share their knowledge and experience with us, but we're going to start with a word of welcome from IBE Africa. This afternoon, we don't have Mr. Action Amos with us. We have the Vice President, and he will welcome us briefly, and then I'll introduce the speakers that we have for today's webinar. Hello.
Hello, Comfort, Musa.
Yes, I would like to have a word of welcome from the Vice President of IBE Africa.
Okay, thank you.
Yusuf, are you connected?
Yeah, I'm connected. So dear colleagues and friends from the epilepsy movement around Africa and worldwide, I'm really happy as Vice Chair to welcome you to this webinar regarding making epilepsy a health priority in Africa, and with support from the IB and Ben Foundation. As you are all aware, our topic today is around epilepsy medicines in Africa. Epilepsy is one of the major brain disorders worldwide, but it is also
Hello, Yusuf. Your mic is muted. Please unmute yourself so we can hear you.
I'm sorry. Thank you very much, dear colleagues and friends from the epilepsy movement in Africa and worldwide. I'm very happy to address you these few words to welcome you to this webinar series organized by the IB Africa in support from funding from the Ben Foundation. As you are all aware, our topic today is around epilepsy medicines, which is a very challenging issue in Africa. And also we are already aware that in Africa, we have 10 million people living with epilepsy according to WHO. And the same report, if we look, stipulate that 8 million people are not treated with readily available modern drugs, which are available at the cheapest of $5 per patient per year. So this indeed constitutes a serious treatment gap. And I think thanks to modern medicine, most of the causes of symptomatic epilepsy in our region can be greatly reduced by prevention and treatment through the availability of anti-epilepsy drugs. I think in order to address the gradual decline in the provision of healthcare services due to the economic hardship experienced by our member states of African region, a resolution has been adopted with the goal to revitalize district health system through the establishment of a community-based management of essential drugs. And this has been stipulated in the WHO African region report, and which also move ahead to include a large number of drugs, particularly those that are in generic form, together with a sustainable and efficient quality control. So to end, I'd like also to recommend the Bamako initiatives with others in the health sector via a sector-wide approach. May I wish you all a fruitful discussions and look forward to your active participation. Thank you.
Thank you very much, Yusuf, for that welcome and general introduction to our topic and focus for today. This is our 7th webinar as we seek to make epilepsy a health priority in Africa. And over the months, we have realized there's a high demand, for the content that is produced during these webinars, because it's hosted online and many people come to watch. And we are having researchers, we're having NGOs, activists, and even some policymakers, tuning in to listen to these conversations. And we are proud and happy that we've been able to cover much ground. There's definitely more to do. And that's why today, joining us, we have Mr. Enos Bashir. Please forgive me if I mispronounce your name. Mr. Enos Bashir is a WHO Technical Officer, Non-Communicable Diseases Integral Services. We'll also be hearing from Dr. Osman Mianji. He's a Kawi Senior Consultant in Pediatrics and Pediatric Neurology. We also have Mrs. Laurie Harriel, Programs Developer with Rowe Foundation, and Mr. David Chotu, CODEF Board Chairperson, Retired Senior Nursing Officer. Now, all our panelists, please, we will give you 5 minutes to speak to us briefly, and thereafter we'll have the panel discussion with questions from those who have joined us. We already started receiving questions once the poster and the announcement went out. There are people who already started sending us questions, and we will have these conversations and the questions after you've all given your introductory remarks. We hope to round off with this conversation by 2:30, so we plead that you all stick to time, so we'll have enough time to discuss the issues and respond to the questions that may come in. Again, I would like to request that we mute our microphones when we are not speaking to avoid the noise and obstructive sounds from the background. That said, please join me. Welcome. Yes.
We're supposed to play a video first before the panelists do their introductions.
What's that? Sorry, I didn't hear.
We're supposed to play a video first before the panelists get it. Please.
Okay, so permit me, we will get that short video, and immediately after we'll hear from Mr. Enos Bashir. We'll start the conversations with him. Again, try to keep it to 5 minutes. So yes.
People with epilepsy suffer, and my heart bleeds to see this continue. I've come to know that epilepsy is one of the leading causes of disability and the second leading cause of death worldwide, and that it affects over 10 million people in Africa alone. I have come to know that the risk of premature death in people with epilepsy is 3 times higher than in the general population. I have come to know that epilepsy is a treatable condition and can be treated at a very low cost.
It is saddening that the current treatment gap is over 75% in most low-income countries. There is lack of access to medicines, and there is high discrimination and stigma associated with epilepsy from grassroots communities to global level. If you and me are to leave no one behind, as per Sustainable Development Goal 3 of ensuring healthy lives and promote well-being for all, we need to consider prioritizing epilepsy in the health agenda of African countries and beyond.
So we also have challenges on anti-seizure medications. I've mentioned that we only have the standard anti-epileptic drugs, and we know that the treatment gap is very large based on the studies that we've done, with about 64% of the people with epilepsy not receiving appropriate treatment because of obvious reasons to do with the costs involved in purchasing those drugs, and mistake drugs, as well as misperceptions about epilepsy, a lack supply of anti-seizure medication.
Hello, I'm Fides Peter Wiso from Tanzania, a mother to a son with epilepsy, also a founder of Tanzania Epilepsy Organization. We are still facing the anti-seizure drug shortage, and this shortage will cause more complications to our children and even death. So please let us unite and do something about this.
Ligama ngibanele Gametse waseveni laseSwatini. Ngiphila nesifo sekuwa. Sinebulukhuni lapha eSwatini ekuthola amaphilisi esifo sekuwa. Please make epilepsy a health priority in Africa.
Melo pa David Tushu for Cameroon. Megizela Zakum ko Yanshin saying to them. See Kwan water, Mamma so Zako fashion say.
Mofi Valentine, Maluva Cameroon. Uto e kike fwe kwa Cameroon.
Marubesa Sudan. Marubiada Varapaparba. Mala Inderia Mapadawasi. Hagumata Dawate, the Birika Mufuni separasi. Malakwa Murinda Inderia Mapana Gazaka Ambasi. Mala Sukulia Tajina Gupa Inderia Mapana Sukulia Gazaka Basi. Sudanisi Marbe Karapapa Male Tao Mori Copa Marbe Go Pagika Baduniani Adunangwanya Aba Dora Mo Pane Dawasi Ngonya Gembo Mori Sukulia Male Parata Dora Mo Pane Aza malarinho morite birka mufuka Maromata ngo gudawote male ngazo muri aduna kwa mopane andero
Jina langa ndini Francina Gondwe ene makala kunoko ku Malawi vuto likupita likukulira menelirira kusowa kwa mankhwala mu zipatala zosiyana ku Malawi kuno nene mafuno kuti ndipemphe kuti tatiyeni tigwiraneni manja kuti tithandizane kuti vuto limene lililite. Let us unite and fight against this problem.
Hi, my name is Simone Myberg. I am from Johannesburg, and I have a sister who has been living with epilepsy for the past 25 years. I just want to say that it's important that we make epilepsy health a priority in Africa. Thank you.
Point in time. Let us prioritize the treatment of epilepsy, increase access to anti-seizure medicines, deal with poverty, and increase the number of trained staff. All this will help reduce the treatment gap. The establishment and implementation of strategies for the management of epilepsy, particularly ones that will improve accessibility and promote affordability of safe, effective, and quality-assured anti-epileptic medicines, as well as include essential anti-epileptic medicines into national list of essential medicines.
epilepsy affecting 50 million people globally. That is about 1 in every 100 people in South Africa. And up to 70% can live seizure-free with a proper diagnosis, treatment and meds. All this for only $5 per year. Really? You might ask me. Well, that's why making epilepsy a global priority will impact not only the national health sectors, but the global burden of diseases. So what can I do, you may ask me? Well, you can become informed, you can help create awareness, and you can be part of the change. I'm Grisham Africa from Epilepsy South Africa, a chapter of IBE Africa. I'm a person with epilepsy, and we need your support. Thank you.
Into the conversations. We have Dr. Enos Bashir, we have Mrs. Lori Harriel, we have David Tuchu and Dr. Osman Mianji. Again, Kenneth says he cannot hear me. Are other people having the same challenge? Can you hear me? If you can hear me, please leave a message in the chat so I know I'm audible. Is the sound okay? Okay. All right. Thank you, Florence, because I just got a message in the chat from Kenneth that he could not hear me. So I was saying we are going to proceed with our conversation for today, centered around the question. We're trying to find answers to why are we still facing the unending challenges of epilepsy, and we will be getting the perspectives of different health service experts telling us what we need to do at national and regional levels. And so Dr. Enos or Dr. Osman, if any of you is ready, let me know, and we will start with you. So Dr. Enos Bashir, are you ready?
We are ready.
Again, he's a technical officer at WHO NCD Integrated Services. Okay, the floor is yours, and would like to give you 5 minutes for a start.
Thank you so much, Comfort. Can you see me on screen?
Yes, we can.
Great. I'm just gonna share my computer screen if that's possible. Can you see my PowerPoint at the moment?
Yes, we can see your PowerPoint.
Great. Fantastic. Display. So which screen can you see at the moment? Can you?
We have on screen shortages, improving access to medicine and health products.
Fantastic. Thank you so much. Great. So I am Mr. Bashir Enos, and I'm in the non-communicable diseases department, working on improving access to medicines and health products, specifically within the space of integrated service delivery. I prepared a few slides for everyone, and I know I have limited time, as Comfort's just said, in terms of only having 5 minutes, but I'm hoping to at least give you an overview of some of the challenges we experience within the space of access to medicines and health products, specifically non-communicable diseases, and of course how it affects epilepsy as well, and everything that falls within the space of this disease area. But I think most importantly, when I got the invitation, I think what we really need to concentrate on is solutions. And I'm not going to go through a lot of the statistics at this point in time about the things that most of us know already in terms of there being insufficient access to services and support for neurological disorders, specifically in our low to middle income countries, from everything ranging from workforce to stigmatization, discrimination, and limited access to the medicines, diagnostics, and technologies. I think it's important to know, and all the statistics are out there, that 3/4 of people living with epilepsy in low to middle income countries do not get the treatment that they need. So increasing the risk of them dying prematurely and condemning them to many of a life of stigma. But what I really want to concentrate on today is this slide over here. And I'm sure everyone can see that it has two main areas to it. And if you look at the bottom, there's a word called supply and there's a word called demand. And the most important thing I want to make colleagues aware of and our participants online is that the only way a health system works effectively in terms of ensuring access to essential medicines is if we have rational selection, affordable prices, a reliable health system with supply systems, and sustainable finance. And about 4 years ago, there was a lot of work done around shortages and stockouts, and understanding what causes a shortage, what causes a stockout, and what these definitions are become so important. So on the supply side, this is everything that's related to upstream. And within a COVID environment that we've just experienced over the last 18 months, approximately, we've seen many challenges related to the supply side, being manufacturers, being shipping ports being closed, being no flights available, be it transport of via train, via road, via vessels on shipping, or even via air. On the demand side, we've also seen shortages at the PHC level, at the country level, be it in our clinics, be it in our central medical stores, or at any value chain point that a patient accesses services. So having looked at the supply and the demand challenges and those potential risks, there are possible strategies that can be put in place to address this. Some are long-term strategies and require a lot of work, where others are strategies that are more for the short term, and also those associated with mitigating future outbreaks like COVID-19, and how do we make our systems more resilient. And I just want to share this slide specifically on the various areas of how COVID-19 has affected essential medicines. We've seen that specific products has had a huge surge because of COVID-19. Some, of course, related to them being used for the treatment of COVID-19, but others specifically related to hoarding. And what do I mean by hoarding? I mean specifically, there is a panic in the system that we will not be able to get medicines, and therefore we order more than what we actually need, or we stockpile. We see that suppliers cannot get raw materials to make their finished products or their finished medicines, specifically in India and China. And as you see across this full value chain, there have been various parts of the system that have been affected. We have seen domestic funding for specifically things like NCDs, completely now being even made smaller in terms of budgets to accommodate COVID-19, specifically on the African continent and within the budgets that they have currently available. We have seen as well that we have short prescriptions. If a patient goes in for 1 month's medicine, he might only get 2 weeks. But these are the realities that we are currently dealing with. And how do we actually move towards an approach where we try to accommodate within the systems that we have? And some of the solutions that have really come out over the last couple of months, especially around interviews that we've done with various suppliers, interviews we've done with various companies as well, UN agencies and donors, but as well as with specific member states, we're starting to see a few emerging trends on how do we ensure access. Yes, we need to ensure in the short term within the COVID environment, but we also need to ensure that we have the relevant funding to support our current systems, specifically in NCDs, but also making sure that every patient at PHC level has access to the medicines that they need. And you'll see some of the solutions that have really come through is about having multiplying sources of production. You'll see a lot of information going in the media now about improving local production and multiplying these sources of production, not only being dependent on companies that are situated off the continent, but also medicines is not the problem at the country level. There is sufficient stock, but we just cannot get it across the value chain to our patients. We've seen multi-month dispensing where patients get 3 to 4 months medicines at a time to limit their ability to go to the facility, stand in a long line, and potentially end up contracting COVID-19. So there have been things that have been put in place we have made sure that we're trying to assess the situation to be more resilient, but there is no magic bullet. Everything is context specific. Everything involves a full understanding of your full value chain at the country and regional level, and making sure that you're scaling up in the right areas based on the context that you have. So whether you put in risk mitigation strategies to avoid stockouts at the PHC level, or whether you're working at your national level with tenders to make sure that you have sufficient contracts with suppliers, across your full value chain, I would encourage us to work towards full end-to-end visibility to support our staffing on the ground to be better at ensuring that we have access to these important commodities at the level where it's needed the most. Thank you so much, colleagues, for allowing me the time. And I now hand the floor back to you, Comfort. Thank you so much.
Thank you for your presentation. I definitely have questions for you, but I will wait until we've heard from all the other panelists. Thanks again, Bashir Inus from WHO. We'll now hear from Dr. Usman Mianji, Kenyan Association for the Welfare of Epilepsy. Dr. Usman?
Thank you. Good afternoon to all. It's good.
Good afternoon.
It's a privilege now to talk to you. Now, since the time is limited, I do not want to repeat a lot of things that have already been said. And Bashir has covered quite a lot of ground in his little short talk. So what I'm going to tell you is a little bit about, we'll share some experiences that CAWE has had over the years. CAWE was established in 1982. It's probably the oldest organization, NGO, non-profit making, probably in Africa, if I'm not mistaken, to the best of my knowledge. So now, let me just share our experiences about how we have been able to monitor and reduce the cost of anti-epileptic drugs and make them affordable to the public. So now this is, and just to highlight to you that we have used mostly generic drugs, cheap generic drugs, which we buy in bulk, and then which are affordable to the patient and to everybody. And our results are similar to anywhere else that I know of. And then this is just to show you a pie chart of the kind of drugs we use. Right? Yeah, so if you look at the kind of drugs we use, majority of the drugs are generic carbamazepine, phenobarbital, and phenytoin. That forms more than 80% of the drugs that we use. Next, this is next here. Yeah, just to show you the, sorry, there's some, yeah. Okay, you can also see the number of patients that are on monotherapy, about 66% on monotherapy, and only about, polytherapy really means 2 drugs, so 30% to 96% are on 1 or 2 drugs, and very rarely we have cases that are on more than 2 drugs. And okay. Now, all these, after all our experience that we have, 70% of the patients' seizures are well controlled. That means they're fully controlled. As you already mentioned to you, 66% are on monotherapy, 30% on 2 drugs, and a few on that. And majority of the combinations, if at all there are any, are carbamazepine and phenobarbital. And as I told you, most of the drugs that we are using are generics. Now, this is what we analyzed recently in the last 6 months, from December 2020 to May 26. See, the seizure control now. That means no seizures in the last 6 months 1,400 out of a total of 1982, which works out to be, well, and then about 1 to 2 seizures in 6 months, 3 to 4 seizures in 6 months. Let me tell you, those who treat seizures or epilepsy will tell you that these figures are very insignificant. 1 or 2 seizures in 6 months is very little. So that's as good as very good control. The ones that are well controlled are the ones that get more than 4 seizures in the 6 months, 163. So almost 70–80% are well controlled. Then we have, this is the whole year now, from May 2020 to May 2021. If you look at the number of patients, last time, the last slide that shown about 6 months was about 2,000 patients. This is now over the whole year. That means fully control over the whole year are almost 3,000 patients. Then 1 to 2 seizures, 610, etc. Right? So again, we are looking at 80% are well controlled. All right. So now the side effects that everybody worries about from generics and the kind of drugs we are using. So everybody in the past, even up to now, people talk about degrade the use of phenytoin and phenobarbital, but our experience is very different. This 6 months, this is the kind of figures we had of side effects. 1 of ataxia, headache, 5, all that. Total is about 16 or so. Patients with some side effects that the patients reported themselves to us. So no serious side effect that we have encountered. Okay, then so now you can see from our experience that we can do very well with the generic drugs that we are using, and control is excellent. I mean, it's as good as anywhere else, and the cost to the patient is very little. I'll come to that in a minute. Now, important thing is, and these clinics, the main thing is to train primary healthcare workers right at the grassroots. That's the most important thing. And that also helps in reducing the treatment gap, as we always talk about. Of course, we need to create awareness and all that. Now, everybody is talking about non-availability of drugs at the grassroots. People talk about it. The Western world always tells us in low-income countries that drugs run out at the grassroots or the dispensary level. Look here, that's only half the truth. It's not the truth. Because you provide, like in the Ministry of Health, when we introduced our first guidelines of managing epilepsy, we convinced the ministry to provide some of the basic drugs that we have listed there at the grassroots. And they helped us to give those drugs. But would you believe it? Many of those centers, even at the health center level, not at the dispensary, were returning these drugs to say there's no demand and people we're not using them. That is not the truth, because the people working in those areas are clinical officers, community nurses, and these are, if they're not trained to look after epilepsy, they're going to pass on these patients to the next level. Because many of them, even doctors, are scared of treating patients with epilepsy. So they would rather have somebody else handle those cases. So first thing is provide the drugs, but train those people. If you don't train them, then again, the drugs will be returned. Then the same mantra will follow, oh, there are no drugs available, no drugs available. Because in our experience, they are returned because people at the grassroots are not properly trained. And then unless you train them, they're not going to help us in tackling these problems. And now just some of the myths, of course, that we all have is that epilepsy must be treated by neurologists. But that's not true, because most of the African countries don't have enough neurologists. Okay, Kenya has about 30–40 neurologists at the moment, pediatric as well as adult, but they're not enough. If you have 110,000 neurologists in population, then I don't think we'll ever achieve that. And then, so we have been able to handle those clinics. Even our own clinics are run by clinical officers. And then there's again a myth about that you must have EEG facilities available to treat epilepsy. That is not true either. And then again about the treatment of epilepsy is expensive. Again, we have proven that it's not. The cost, as we have mentioned, and we have shared these results with IBE and African Epilepsy Congresses many times, is less than, well, at the moment the prices have gone up a little bit, $5. It's like only phenobarbital, phenytoin, you'll be even less than that. So $5 a month is unaffordable. This is to the patients. To the patient, not to the an NGO like ours has very limited resources. We don't have enough resources like the county governments or the central government. And I mean, if they can learn to buy things that are affordable and for themselves and for the taxpayer, it can be done. So we've had several meetings. Now, the training of the health workers has to start from the training institutes. As far as the paramedics are concerned, in our country, the primary healthcare workers mostly are community nurses and then volunteer community health workers plus clinical officers. Those are our main force. Now, they have to be trained and they were given more better curriculum at the training institutes. In our case, this is the Kenya Medical Training College, which is trains all these paramedics. And we have proven it with our clinics, our demonstration clinics, and are run purely by clinical officers. Me, I just act as a consultant and I just assist in difficult cases. And then it should also pass on to the medical school. Don't forget the medical school and the medical students. I have been through the medical school. I have been through the postgraduate school. The amount of epilepsy training was very limited, hardly any. So we have to improve the training. Okay, we have to get convinced that the government the counties must help us to understand. But if people don't understand the problem of epilepsy, like for example, in Kenya, we have about 1 million cases. 1 million cases are just people who suffer from epilepsy. But the population which suffers is about 10 times more than that. People forget this is a social disease. A social disease means there's one nuclear case, then the parents, of course, have problems. The siblings have problems, grandparents have problems on both sides. So we are looking at almost more than a dozen people who under one nuclear case. So if you are looking at 1 million cases, actually, the people who are suffering are about 10 million. So people must understand the burden of the disease is not just actual cases. So anyway, I would like, there are many things we can still discuss because Kawe has been involved in this work for many, many years, for almost 40 years. I've been associated with it for 40 years. I'm the chairman right now. But we try our best to do whatever we can with our limited resources. Thank you very much.
Thank you very much, Dr. Osman. Thanks for that presentation. There are questions for you that we will share later, but I just want to take a quick comment from Adam Janin, who says, thank you for highlighting this, Dr. Osman. That's the situation now in the Gambia. The demand for care is more than the healthcare workers on the ground with knowledge of epilepsy care and management. For the questions, we will share them with you shortly after we hear from the other panelists. Straight away, we will hear from Mrs. Laurie Herrell, Program Developer Role Foundation. Good afternoon, Mrs. Laurie.
Thank you. Thank you, everyone, for inviting me to join the panel today. I'll just share my screen. Uh-oh. Sorry, I'm having a little trouble with the share. Hold on. Sorry, trying to get this share happening. Oh my goodness, I'm so sorry.
No, it's okay. Take your time and sort it out. Technologies and the challenges.
Yeah, we usually use Teams, and so I'm not as adept with this.
And Laurie, while you sort it out, please just permit me read some of the comments that have come in the chat. These are not questions, of course. Questions will be answered later, but we have comments from Abraham, who says, Dr. Osman. Okay, this is a question. Abraham, I'll come back to that. But we have Dr. Prince Kazadi, who says, thank you, Dr. Osman, for the presentation. The training of primary doctors and nurses is the first step to improve management of epilepsy, and I started this project in the Democratic Republic of Congo. Thank you, Dr. Kasadi. It's good to hear from you and learn about what you started. Of course, we're wishing you all the best with your project, and we're coming back to Laurie. Have you sorted out?
So sorry, hang on one second here. I think I've got it now. Oh, I'm so sorry. You know what, I'm gonna go through and just share just a few comments. I'm so sorry that the presentation's not working, but I'll just run through the information. So good afternoon. Oh, go ahead.
If it's a presentation that you can share with us, we would email to the participants who are interested.
Yes, I will send it to you. And again, I apologize. So I'm with the Roe Foundation, and we are a U.S. private foundation and a social enterprise partner with OWP Pharmaceuticals in the U.S. We have a mission to improve the quality of training, diagnosis, and treatment available to people with epilepsy in under-resourced areas of the world. We've been around since 2015, and in that time, we've worked with 57 partners in 29 countries globally. Since 2016, we have granted more than 145,000 prescription months of 2 anti-epileptic medications, Roipra, which is a branded generic levetiracetam, and also Subvenite, which is a branded generic lamotrigine. So we have ongoing medication grants to 20 partners in Africa, and that encompasses 12 countries across the continent. We also have 10 new partnerships in active development, including partnerships we're putting together in 6 new countries. So we're hoping to expand our reach across Africa. In 2020, 11% of our medication grants total were delivered to Africa at about a wholesale acquisition value of $1.96 million. And that's just to say that we're committed and here for the long haul to help people with epilepsy in Africa. As an organization outside of Africa, I was asked to present and address a few of the barriers we've encountered in trying to deliver anti-seizure medications to Africa. And some of these barriers we've been able to overcome. Others still need more attention, and perhaps this group can help us work through some of those. So first issue we have is thanks to the miracle of social media, we have contacts from all over the world, and that includes many smaller organizations within Africa. And those are community-based organizations frequently, and very small organizations. And we want to work with everybody that we possibly can. And so even the smallest community-based organizations, we want to support them in any way that is feasible. So one of the issues, though, is that some of the community-based organizations often work at a very local level, in a small area, and they often lack a formal legal structure. So something to bear in mind is that US foundations and charities such as ours must follow our federal regulations for making grants. And so being registered within your locality is mandatory and also just a very basic first step. There's other criteria to meet, but it's just something for organizations to bear in mind when working internationally. Also, some of the smaller organizations may not offer clinical services, but clients need medication, and we understand this. And so, however, granted medications must be managed by a qualified healthcare provider. And so one solution that we've worked through with a couple of partners is that the smaller organization can often align with a nearby larger organization that has clinical support and work with their physician. And this accomplishes a pooled procurement of medication. Another issue that we encounter are importation issues, and sometimes not understanding national importation laws can result in extreme delays and additional expense to the NGO or CBO. And so a good solution there is knowing and complying with all importation regulations to give you the best chance at successful importation of medications. And another importation barrier we've encountered, or that actually the partners encounter, is that partners in at least 3 countries we've worked in have encountered charges and extra fees, in quotes, to have their shipments released. This is an issue we can't address from our side here in the US. So just a question to the group in general is how can off-book charges, call them what you will in your locale, how can those be addressed in your country? This is a major barrier, just the expense it creates, and certainly not goodwill when someone's trying to do nonprofit work. And then one other issue we've encountered, kind of an ongoing situation, is national formularies. The drugs that we provide are most frequently are levetiracetam and lamotrigine, and often these are not part of a national formulary, especially the levetiracetam. So we have one NGO that's requested medication, but in going through the channels at their end, they learned that they first have to petition to add levetiracetam to their national formulary in order to dispense this drug. Sorry, I'll back up there. One NGO found that they have to petition to add levetiracetam to the national formulary in order to dispense the drug at a public health facility. Now, what this means to them is they have to convene a meeting of the drug authority and other parties. This is at their own expense and without a guaranteed outcome. So this brings a question of, will WHO consider adding additional anti-seizure drugs to their essential medicines list, which would then become part of many national formularies and make it easier for potential partners to use those medications in their country. So that's just a brief overview. And as we say at Roe Foundation, epilepsy is a global problem that deserves a global solution. We want to be part of that solution, and we know that IBE Africa and many African epilepsy organizations are doing just that, trying to achieve solutions in their location. Just know that you have our continued support. Thank you for raising awareness, improving care, and making epilepsy a public health priority across Africa. Thank you.
Thank you very much, Lori, for that presentation. I will just take a few comments that came in. We have Dr. Kazadi, who says, thank you very much for your support to epilepsy patients in the Democratic Republic of Congo. Your support has brought positive impact and results to epilepsy patients in the DRC. And there are other comments which I will encourage all the other participants to read the comments in the chat, because we may not be able to take all. And please permit me just acknowledge the presence of WHO Regional Advisor, Dr. Florence Baingana. She's here with us. And also Dr. Fatima Batou from Geneva, that's WHO in Geneva. Our last panelist this afternoon is Mr. David Chotu from Community Development and Epilepsy Foundation. David, like the other panelists, we give you 5 minutes, and after that, we'll get into all the many questions that have come in. Good afternoon, David. Do we have David online? Hello, David. I'll try again.
Can you get me?
Oh yes, we can hear you now. Good afternoon and welcome.
Good afternoon. You have reduced the time to 5 minutes instead of 10. Well,
so that we can have more time to take questions.
Yes. I want to be sure that the topic is to find out why Africa is still facing the challenges of medication shortages. Is that what I should talk about? Okay.
Yes. That's what we're talking
about. I have three reasons why this comes about. And the first reason is non-prioritization of epilepsy, seen by the non-inclusion of epilepsy activities in national health plans in many African countries, including Cameroon. This is a huge problem that inevitably impacts epilepsy medication availability negatively. And solutions that are proposed for this at national level is that each country government should put in place epilepsy care structures at the central, regional, and district levels and empower them with appropriate personnel and logistics, just as it is done for malaria, HIV/AIDS, tuberculosis, and COVID-19. At the regional level, I propose that the solution should be IBE Africa should work harder to overcome the chronic lack of funders for their chapters per country to push further advocacy activities for making epilepsy a health priority. A second reason for this challenge is war and the conflicts that are so rampant in African countries, destabilizing healthcare activities just as they do for every other activity. The war in the two English-speaking regions of Cameroon, for example, has destabilized the normal functioning of the Northwest Special Fund for Health, which is responsible for drug distribution. Also, population displacement, including people with epilepsy, further makes the situation worse. And as a solution, I propose that at national level, health authorities should develop alternative drug distribution techniques and assessment of population needs to avoid drug stockouts, which can lead to sudden death in epilepsy, which is called SUDEP. An example of an innovative system of assessment of population needs has been developed by CODEF in partnership with Northwest Special Fund for Health. This system is called CODEF Community Drug Monitoring System, in which CODEF community agents check the availability of drugs monthly in each health facility and reports to government through the Northwest Special Fund for Health promotion. This civil society monitoring of government action is a best practice that can be funded and expanded. As for a regional solution to that, I say IBE Africa can look for funders who can invest in this best practice of monitoring drug availability for other war-torn countries like Burundi, DRC, and South Sudan. A third problem, or a third reason for that problem, I see as administrative bottlenecks and inertia, which is a common phenomenon plaguing many African countries. An example can be seen in Cameroon, where a good initiative has been met by putting in place a focal person for epilepsy at the ministerial central level, but this decision has not been taken to the logical end by putting in place regional and district structures. So solutions to this problem I propose at national level should be epilepsy care structures should be set up simultaneously at the central, regional, and district levels and funded to facilitate and funded for activities accordingly. At the regional level, I propose that IBE Africa should organize, I call it stimuli tripartite meetings. Stimuli tripartite meetings and webinars that will involve WHO representatives, ministries of health, and IBE chapters of each country to emphasize the need to accelerate the making of epilepsy a health priority in their different countries to be a reality. So, in conclusion, I would like to say that these three challenges, non-prioritization of epilepsy, armed conflicts or wars, administrative bottlenecks, if well tackled, and with the commitment of governments of African countries, the issue of drug shortages for people with epilepsy will soon be a matter of the past. Just to rush through, I have brought this, which can be, I can send it by online for others to see. I just rushed through it to meet up with the 5 minutes that I've been asked to present. Thank you very much for your understanding.
Thank you, David. And yes, please do share your presentations with Action Amos, and he would pass it on to the participants. Again, we want to thank Yusuf, Dr. Osman, David, and Laurie, and Enos. Thanks for all your amazing presentations. We had questions before the webinar and some questions sent to us as the presentations were going. We have 36 more minutes on our clock, and so we will try to go through as many questions as we can within this short time. And I would like to start off from a question that Laurie asked during her presentations. You know, when we're looking at the issue of drug stock out and perennial drug shortages, she raised a question of how do local organizations and hospitals, how do you manage, how do you address the issue of off-book charges that come in with trying to acquire some of these medications? Dr. Usman, Enos, David, can you respond to that? Because that came out of Laurie's presentation.
Could you please repeat that question? I'm sorry, I didn't hear it properly.
So Laurie was sharing about their experience with trying to meet the needs of certain organizations on the continent, and she asked, how can off-book charges, I don't know what you call it in your country, but how can off-book charges be addressed? Because this is a big issue for organizations and hospitals trying to import certain important medications for persons with epilepsy. And Laurie, if I didn't capture that well, maybe you can ask or rephrase that question.
Yeah, if you need clarification, sir, it's just, we've had organizations, they go, you know, the package is cleared and they go in to pick it up, and then there's additional fees, and makes it very difficult for a nonprofit on a very tight budget to, access a package that is rightfully theirs. We pay the duty in advance, but yet there's still fees that need to be addressed.
Thank you for that question. It's relevant, and it's something I've heard even with smaller organizations in Cameroon, some who don't have the budget, to clear this off-book charges, and there are important medications that they can't access because of this charges. So how do you manage it in your context, Dr. Usman?
All right,
and,
thank you. I think I've got some idea of what you're getting at. It's not the overall problem. It's just you're talking about donations by organizations of medications and things like that, and how they can be cleared by the authorities, right? The customs and the pharmacy board and all that. Is that correct?
Yes, it goes beyond the official, the official.
Yeah, and just to add, we have Tolu Olaniyan, who is saying their partners in Sierra Leone experience this off-book charges often. And within the context of the conversation we are having today, this can actually deter many small organizations from getting essential medication.
Yeah, they feel intimidated.
So how do you manage that?
Goodness, what's happening? Can you hear me?
Yes, we can hear you.
Okay. Laurie, we would like to work with you, and I'm sure you can help our organization. And we'll find ways of getting the drugs to the people who need it. Unfortunately, the bureaucracy sometimes can be very difficult to deal with. We've had some donations from other foundations, including the American Epilepsy Foundation. And of course, we know they mean well, they want to help us, but sometimes such organizations from outside ignore the fact that we have regulating bodies in our countries. See, when you introduce any medication in the country, they have to pass through the regulating bodies, especially like in Kenya, we have the Pharmacy and Medicine and Therapeutics and Poisons Board. Everything that enters the country first must be passed through them, and then they are licensed to be distributed. Unfortunately, that is a slow process, and sometimes it defeats the purpose why the things were donated. So there are no shortcuts sometimes to get these drugs directly from an organization who wants to give. Unfortunately, there may be charges involved also when they are looking at these drugs. You see, in the past, even when I was talking to our late friend Anthony Zimba, who was representing Africa, when we talk to some of these organizations, please consult us before you donate. Consult, each individual country has its own regulations. Then we'll be able to.
That's understood. That's totally understood.
We will be able to guide you better. Each country will
have.
No,
we do comply with that.
So, like for example, these ones brought some drugs, useful drugs, in a suitcase. Now, without passing through the regulating bodies, and we could not dispense them because then we could not get more. If you supply one brand of drug, in epilepsy, you have to stick to the brand. If you keep changing brands, then also you upset the control of the epilepsy itself. So now they brought it in a suitcase. They meant well, but you see now we had advised them not to do that. They said, let's consult us first, and then we will guide you how to use those drugs. Okay. But then, unfortunately, they just gave a bulk, okay, say a few hundred, whatever, and that would last you for in our organization less than a month. And then I asked them, what happens next? Are you going to continue with the supply? And then there was no answer. It has to be a continuity maintained. All right, thank you.
Yeah.
Okay, thank you, Dr. Osman. I think we really need to think about this further and look at these regulations and how they affect, the organizations, because in the comments I see Tolu and other comments saying off-book charges are an issue affecting the organization. Thanks for raising this, Laurie. I think we will need to think about this more and see how smaller organizations can be helped, and maybe in future, those who have dealt with this and how did they overcome. My understanding, it's not about non-compliance to regulation, it's about off-the-book charges, the ones you will not see written in black and white, and how they're affecting the work of different actors on the ground. Mills, you had a question about the recording of this webinar and where you can access it after. Please do follow IBE Africa pages on Facebook and Twitter, and they will always share the links to the recordings. There is a question that came in before the workshop before the webinar, sorry, about COVID vaccines and the medications that persons with epilepsy on the continent are taking. Has there been any study to show that it's okay? Is it okay for persons with epilepsy to take the COVID vaccines? I leave that question open, and any of the panelists can respond to that. The COVID vaccine, is it safe for persons with epilepsy on the continent to take the vaccine? Mr. Enos, Dr. Enos, sorry, I'm seeing the documents I have Mr. and I have Dr. So sorry, I'm mixing up the titles, but Enos or Usman, can you answer to that? Since we're talking about drugs, someone just asked if it's safe for persons with epilepsy to take COVID vaccines.
Okay, this is Osman, doctor. The COVID vaccine, we had guidance from the International League Against Epilepsy and International Bureau against International Bureau of Epilepsy. As soon as the COVID problem had started, and then even from India, where now there's a large number of cases, even from India, the epilepsy group there, and it's a very large group there also, they have all recommended to give the vaccine. Now, this vaccine depends on what vaccine. AstraZeneca is given above 18. You see, now they may start a little younger, but epilepsy is not a contraindication for COVID vaccine. You have to give, unless sorry, epilepsy per se. Okay, if there are other illnesses, that's another thing. So, to my knowledge, it's not a contraindication.
Thank you. And we have a comment from Leslie Donnelly, who says, I have had both COVID vaccines and I have been okay. Sore arm and headaches, only no seizures. Thank you for that. A question to, I think, all the panelists. Are epilepsy drugs expensive? How affordable are they for the everyday African? Let's look at cost, because you have talked about many different issues affecting drug supply and the stockouts and the drug shortages. How affordable are epilepsy drugs on the continent, based on which country you're speaking from? So Dr. Osman Enos, Mr. David, how affordable are these medications in your country?
I'll allow Usman to go first and then I'll follow. I have a few comments.
Okay.
Yeah.
Okay.
You want me to answer?
Yes, Dr. Osman, how affordable or how expensive?
I think if you were not asleep during my presentation, I had already highlighted some of the costs involved. I have the actual cost in my country because we have generics mostly from India. India now is the biggest producer of generics in the world. Okay, so, and their prices are very reasonable. Okay, unfortunately, some of the markups come because of our own bureaucracy, because by the time they're approved and all, money exchanges hands among lots of officials, and then this money is then marked up for the patient. But still, the cost, shall I give you some examples without naming without naming brands, because brands, we are not allowed to do that. Okay, now supposing we take the lamotrigine, okay? That is now in use, but we use very little of that. Lamotrigine, the brand product is about, where is the price? Yeah. The brand product is, let's say, let me give you some in shillings, okay? 230 means $2, okay? US dollars, Kenya shillings. And then if you look at the price that we use is 40 shillings, which is to the patient. 40 shillings is 4 cents or 40 cents. Are you with me? 40 cents, and then this is 230 shillings, which is, I mean, you have to do your calculations. I think those who are experts in maths, but it's a huge difference, okay? So I can go with all the lists if you want the branded list. Luckily, like carbamazepine is the one that is now used widely in our clinics. See, we have 3 clinics run purely by our own clinical officers. We have about registered patients, about 16,000, about 6 to 10,000 are regular followers. So our experience is not small. It's quite a big experience. And the figures I gave you, you can see the percentages were on monotherapy. And carbamazepine, for example, is only about 3 shillings, 3 cents, US cents, compared to about 40 plus, okay? So look at the difference. Now, if you stick to the primary drugs now, okay, without going into these new drugs tend to be more expensive. The multinationals, unfortunately, now, I'm talking to Africans now, remember, multinationals will push their drugs, don't forget, and they will degrade all the previous old drugs to say they're not good. I've told you I've used all the old drugs without any major problems. I've given you all the figures. So phenobarb, phenytoin, carbamazepine, even valproate, excellent drugs. You see, levetiracetam now is available in generic form. But even the generic form is about 10 times more than the primary drugs. Understand? It's an excellent drug. I'm not saying it's not a good drug. It's an excellent drug. But now, unless we have a good donor like Lori, who can give us these drugs on a regular basis, once we start a patient on this drug, means they have to continue. See, we've had many offers of donations, but the donations are limited for a period. The epilepsy patients need them for a long term. And then some of these, our organizations depend on the goodwill of donors, you see. Now, if without donors, we cannot survive either, see. So we have to stick to, so I think the choice of drugs, I'm talking about the primary level in the low income countries, okay? Those who can afford it, of course, you can use the more expensive drugs, whatever they are. I think that's all I can say now. I have examples of all these drugs if you want, the cost of drugs.
Okay.
But anyway, the main point I've made is that they're expensive.
Thank you for responding to that. I have so many questions for Bashir. So permit me take 2, and then the next ones will be for Lori. So the question is, what is WHO? This is from Tolu Olaniyan. What is WHO doing to make emergency medications easily available to stop prolonged seizures in the community in African countries? Right now, people have to travel long distance to their clinics before they can be given intravenous medication. This puts them at significant risk, including death. In other countries, parents have access to medications like midazolam that can be administered at home to stop the seizure. This prevents unnecessary hospital admissions and reduces the risks associated with prolonged seizures. So the question, what is WHO doing to make emergency medication easily available to stop prolonged seizures in different African communities? So Dr. Bashir, that's for you.
Thank you so much, Comfort. And Comfort, if you don't mind, I just maybe want to answer a few of the questions that that have been asked as well by the various colleagues who are online today. The first one around, for example, the COVID vaccine, and we have seen that, and it's been in the chat box. I saw by colleagues posting as well, like by Janice Brown, that there's no contraindications. We've also seen that with some vaccines that they are safe for epilepsy and for neurological conditions. But we've also seen, for example, the one vaccine that if you have uncontrolled epilepsy or any progressive nervous system diseases with a history of Guillain-Barré syndrome, that it's not recommended to use vaccines. So it all depends. It's an area that WHO is surveying and looking into the safety of COVID vaccines.
Please mute your microphone so we can hear Dr. Bashir.
Thank
Yes,
you.
Dr. Bashir, please continue.
Thank you, Comfort. And then maybe just to other questions around, for example, those almost like what I call out-of-pocket expenditures as well, or escalators. You'd also find, and I'll put it in the chat box as well, that one of our key resolutions is around improving the transparency of markets of medicines, vaccines, and health products. And that specific WHO resolution asked us to look into the availability of data throughout the value chain, in terms of clinical trial data to pricing information, assessing the feasibility and potential value of establishing web-based tools. And we've also been doing this in the space of diabetes. We just had a resolution that passed now at the World Health Assembly 74. And the most important thing is that essential medicines have different levels of pricing. What the price of a product is when it comes out of a manufacturing facility is completely different to the escalated price that a patient pays out of pocket in their hand, right? Some, of course, products are, if you depend even going through your public health system, that product could be free. For others, it's extremely expensive if they're paying out of pocket and they're going into the private sector as well. So understanding these escalators over time is an important piece in terms of transparency that we need to take forward. And we have these resolutions that have been put in place to understand what are the sales revenues, the prices, the units sold, the marketing costs, and it all goes under that banner of affordability and transparency. I know that Laurie also asked a question related to specifically the national, or not the national, the WHO essential medicines list. And just to let you know that this committee sits every 2 years in terms of a WHO expert committee, specifically looking on the selection and use of essential medicines. It's a very transparent process and relies on evidence-based assessments of effectiveness and potential harm. So that is a process that takes place every 2 years in terms of looking at the model list and how it gets adapted onto the national list as well. Comfort, coming back to your question specifically around what is WHO doing when it comes to humanitarian settings or when there is a lack of stockouts as well. I think I hear a lot around shortages in medicines, and I'm going to answer that question in a very long way if you just allow me 2 or 3 minutes. The first point I want to make is, when every context that we work in, we got to understand exactly what is the problem that we are trying to solve. What is the barriers to access for that specific context and the regional contexts and the global contexts. And then from there, we have to work out what are the main areas that we want to address to improve that. I think Usman brought up right at the beginning of his presentation around stockouts. If a patient goes home without a medicine, be it, sodium valproate, whatever the medicine is at that point in time, if there is no medicine on the ground, the root cause of that problem could be something as simple as poor quantification or forecasting on the ground, and there's nothing on the shelf at that point in time. And that problem is completely different to suppliers not being able to import product X into the country and making sure that this is on a national medicine essential list and that we can get it to the patient. So where that challenge actually sits in the value chain is something we really need to understand. And we must make sure that for every context, we understand that specifically, whether it's on the demand side, whether it's on the supply side. When it comes to humanitarian settings, there are different ways in which we go about this piece of work. We have what we also call our NCT humanitarian kit that we normally update on a 2-yearly basis for these war-torn areas. And we do we're looking at including things, related to the various areas within NCDs and what that basket of products actually look like. I think some of the challenges is, and I'm actually very surprised that no one's brought this up, because we found this to be extremely effective. And we tried to really, we actually about 2-3 weeks ago, we had a webinar on public-private partnerships and how we use the private sector to make us get to those really, remote areas. And it's everything from leveraging the actual infrastructure, like last mile delivery and delivery of vehicles, taking it to, the most rural clinic that you have in your various districts or states. But it also comes down to not only using the private sector as in to do an actual delivery, but using the skill sets that they have to help us understand what the demand looks like, mapping of disease areas and prevalence to then match the services that go with that. And some of the models that came through quite strongly that really helped some of the countries on the African continent is using the infrastructure from communicable diseases to support non-NCDs. And South Africa is an example of that, where they use communicable diseases. So for example, an HIV positive patient who might have hypertension or might have diabetes, and what they'll do is that they move the service away from a specific clinic, they decongest that clinic, and then they make sure that they take it closer to the patient's home, be it via a private pharmacy, be it by a community health center or a church. There are different models to use around that. So my short answer is that there's no magic bullet. We can provide guidance in terms of how you do allocations, how you do quantifications, how you leverage the private sector. But it's definitely a holistic approach, not only from a WHO context with regions and country offices, but with the Ministry of Health. And it needs to be that comprehensive end-to-end approach. It's not only about the medicines, it's about the workforce, it's about having the relevant finance available, it's about PHC as well, and working towards universal health coverage. Long answer, Comfort, but I hope that answered quite a few of the requests from the colleagues online. Thank you.
Yes, thanks for the answers. Bashir, one more question from Yusuf. Yusuf wants to know what WHO can do to advocate for more epilepsy drug availability in Africa, especially as there seems to be a lack of political will from few member states in Africa to look at epilepsy as a health priority. What can the WHO do at that level?
Thank you. Thank you so much for that. It's a very good question. And I think if I remember correctly, Batul's also online, and maybe she can also answer that, but I'll give from my perspective, I'll give you some of my insights. I think what's very important is to kickstart the policy dialogues at the country level. And some of the work that we've been doing in the various regions is we've been doing surveys specifically at the PHC level, where we sample specifically the primary healthcare health facilities and the private sector, looking into availability and affordability. And one of the key outputs of that whole exercise is not only to support risk mitigation strategy development for countries on the African continent or for any member state for that matter, but it's also to support a policy dialogue with the MOH in that country, so that there is that awareness, that there is that communication of some of the challenges on the ground, to use that evidence to build those dialogues at the country level, at the regional level, and of course, towards a global movement as well. So there are various mechanisms to go about that, but it really comes down to the root causes and having those policy dialogues. And that's one of the key approaches that we're currently using, is by using our survey tools like our MedMon application. And I'm happy to share any information on that, and having that policy dialogue at the country level. Thank you, Comfort.
Thank you, Bashir, for the responses. I see Lindy Way, you have your hand up. Lindy Way, please unmute your mic and ask your question. Please really do keep it short. We have just 8 minutes to go.
Fine. Thank you so much, ma'am. Thank you very much. I would just like to contribute to the issue of drugs just by asking the WHO, is it possible to follow the model of infectious diseases such as that which is followed when procuring drugs for malaria, drugs for HIV, TB, etc., where we could do maybe pooled funding, because in Eswatini, the way that drugs are procured makes it very difficult to secure them. We go for months and months without essential drugs because there's a third person involved in the purchasing of those drugs. So if the WHO Afro region could maybe in some way facilitate a pooled procurement of the epilepsy drugs, I think this would be helpful. Like, for example, I know we've been out of the epileptic drug, we've been out of pediatric drugs even, which is really terrible for the children because without it, they're likely to die. That's first. Number two, is there any essential package of healthcare for epilepsy within the WHO guiding documents, such as the PEN document which exists for the other NCDs like cardiovascular diseases, diabetes, etc.? Does the WHO have a similar package for epilepsy? If it does, could we please have access so we can try and domesticate it for our various countries, and which can be a guiding document, which will also assist in forming the strategic plan for epilepsy. And then this will also give us the guiding documents, or, we need clinical guiding documents, like, for the primary healthcare level, tertiary, etc., which we don't have. Like here in Eswatini, we don't even have a clinic for epilepsy. Epilepsy is given a place in the mental health psychiatric care center only, whereby it's relegated to that because the people are not thought of as being able to be cured, but the ministry is waiting for them to go into complications before doing anything about it. And the Epilepsy Eswatini Association has done a lot already, but they really do need a helping hand through these WHO guiding documents. Thank you.
Thank you, Lindiwe.
Would you like me to answer, Company?
Please do.
Sure. Okay, I'll go ahead. Lindiwe, thank you so much for that question and explaining some of the challenges that you're currently experiencing in Eswatini. So on the second one, I can share all the guidance information with you that I have available, and I can either give it through a comfort and we can share that with you. To answer your first question, pool procurement, very interesting question and a very valid question, specifically because there's two things we need to speak to, right? The first piece is you spoke about communicable diseases and the donor-funded programs, for example, malaria, HIV, sexual reproductive health, that they have their own vertical programs, which is separate to NCDs and things like epilepsy and neurological disorders. So I think pool procurement has one purpose and one purpose only. It's collective negotiation to bring pricing down, right? And there's different mechanisms in terms of how we can go about that. The mechanism one, a really good one, is where the countries came together in PAHO, or the Latin American countries, and they took all their collective information, or should I say the demand. They had the relevant funding, and then they, of course, could service those smaller countries. We have another model called the small island development countries that have done similar things, where the demand is so small that no company or manufacturer really wants to enter that market, but you can bring the prices down by that aggregated volume that you create. There's another meeting that's actually taking place at the end of the month called the South-to-South collaboration, which will be using the lessons from the specific area, the SIDS countries, and the African continent on how pool procurement can be used for the different contexts. And maybe I can even give you the details to that and see if you can get some learnings out of that. Other pool procurement mechanisms can be at the global level, where if you have the relevant financing, and this is a key one, Lindiwe, is where's the money to back this, right? Is there funding available? Because at the end of the day, what people want to see if you're a manufacturer is you want guaranteed volumes, you want guaranteed payments, right? Are you able to pay me in 120 days? And that is the real important piece, is you either have donor funding or you are known to someone known to a supplier that you can pay. So it depends on different models. It can be successful. I'm currently even looking into it at the moment for diabetes medicines and health products. So that is something that we look into so much detail. We're looking into it for childhood cancer medicines as well. And there's so much learnings from this that could benefit the epilepsy community as well, and neurological disorders to see, is this feasible, yes or no? One recommendation I would have, and I'll close at this point, is you have a higher success in building a full procurement mechanism if you look outside of one or two commodities. So if you can find a few commodities that is essential to a collective amount of countries, even if you don't have the relevant financing and you can aggregate demand, you have a higher likelihood of success around collective negotiation. I hope that answered your question, but I'm happy to share anything further on that, but definitely an interesting space and worth looking into in terms of feasibility. Thank you.
Thank you, Dr. Bashir. We have barely 5 minutes to go. I'm afraid we cannot take all the questions that came in. We want to respect your time. So apologies, we're unable to read the other questions. Dr. Kazadi, I see your hand up. But one thing I can say for sure is that please let us continue these conversations like we always say, beyond the webinar. Let's engage on the different social media pages, because sometimes IBE Africa will tweet out some of this comments and content, and we can engage ourselves on the webinar and beyond the webinar. I'm going to give all the panelists a minute just to wrap off as we round up with this webinar, because in the comments and questions, some things may have come up that you want to take a minute, to just round up on this topic of discussion. David, if you all would like to hear from you, 1 minute as we wrap up on this very important topic, access to medications, even as we make epilepsy health priority in Africa, access to epilepsy medicines. David, you have a minute to wrap up this afternoon. Are you there? David? Okay, seems we lost David. I would let Laurie.
Yes,
Hello,
hi, thank you, Comfort. Just want to thank everybody for their hard work. We're coming from the US, we can't offer a lot of the solutions to the problems inside, but just want to know, all of you to know that you have our support. I have met some of the most compassionate and determined people through our partnerships in Africa. And I just share your heart that all of you have the best interests in mind for people with epilepsy in Africa. And just know that you have our support, and our door is always open. And we want to continue the conversations and assist in any way we can. Thank you.
Thank you, Laurie. Dr. Usman, 1 minute to wrap up.
Okay. Well, it's been a pleasure to join this meeting, because I think we've had very good discussion, and good to hear from different people involved in this work. My only message is to people, and I would discourage, this is discouraging our medical professionals particularly, who to me are the ones responsible to make people believe that epilepsy is expensive to treat. We have shown that epilepsy is very affordable, and I don't think people should fear that. And by recruiting more and more people to join the treatment centers and to come forward for treatment and avail themselves with affordable drugs, you will go a long way in reducing our treatment gap, which is a frightening figure, as we all know. It's more than 80% in different areas, but that is really bad. And our primary aim should be to reduce the treatment gap. We should be ashamed that 80% of people do not receive adequate treatment for epilepsy, where epilepsy is treatable and people can live a very productive life. Thank you.
Thank you, Dr. Usman. And Bashir?
Okay. It's David Tuchu for...
All right, please, you have a minute.
Yes, I really think that we have presented talking more of accessibility to drugs, not treatment. So we think that accessibility to drug is what should be emphasized, because we have put on an assessment system of getting to know whether the patients in the field have drugs or not. And we think that is what is more important here, because we are still dealing with a situation where countries have not yet prioritized epilepsy. So the few drugs that are available, we want to know whether they are actually there in the field or not. Not treatment as such.
Okay,
Thank you. That if we can insist on having to see that there are systems where drugs can be supplied in the field. Yes. Everywhere that there is a health facility, there should be drugs. So CODEF has come up with a system of monitoring so as to inform the stakeholders, which is the government, whether or not the drugs are available in the field or not. That is where we are tackling the issue of challenge about shortages.
Okay,
and we
thank
think
you.
that that's the best practice, because it is only in that way that you will know whether the patient, because the patients are the ones collecting the data, assessing whether the drugs are there, and then reporting to the government through the Northwest Special Fund for Health, which is the agency for distribution of drugs. And we think that that is what should be taken as a best practice. And if it is done that way, we'll be able to overcome patients suffering in areas where drugs may reach or not reach, because with that monitoring system, we are able to identify where drugs go and where drugs do not go. And when we give that feedback to the government, they can act.
Thank you, David. Thanks for your input. We will hear from Bashir as we wrap up, please.
Thank you so much, Comfort. And
Bashir, your mic is muted. You'll have to unmute yourself.
Thank you so much, Comfort. Sorry about that. I'll keep it very short, and maybe just to echo what colleagues have said, is that improving access to epilepsy medicines and its health technologies, it's a multifaceted problem, and it's part of a broader challenge in terms of ensuring access to healthcare. We need to look at it from a lens where we actually require an actual robust health systems, which include not only good leadership and governance, adequate financing, we need access to the right information and evidence and quality service delivery, strong health force, and of course, then also the equitable access to these essential medicines and health technologies. They are quality assured because they need to be of the right quality, they need to be safe, they need to be effective, and they need to be cost effective for the country in which and context we're talking about. But thank you so much to you, and thank you to Action and to colleagues for giving me the opportunity today. Thank you so much.
Thank you. We appreciate all the panelists for sharing their time, their expertise with us this afternoon, and we hope they will forward the presentations to Action so he can share it with the participants. There are many messages sent directly to us in the chat, people asking for the presentations and questions about the recordings. Yes, the webinar was recorded, and it will be hosted. Make sure you follow the IBE Africa page on Facebook and Twitter. There you will get the announcement. It was a great 1 hour 30 minutes with you all. We're looking forward to webinar number 8. And look out for the announcement so you can sign up and join the conversation. That one will be on epilepsy and crisis, the experience of South Sudan. We apologize, we are ending 6 minutes after our scheduled time, but I guess it was time well spent. Thanks again for joining us, and until next time, it's goodbye from me.